talk, I'm going to try to synthesize our understanding of how aqueous humor dynamics affects various glaucoma conditions and the management of those conditions. These are the learning objectives for this talk. Mainly, it's all about aqueous inflow and outflow and how that affects intraocular pressure. And between inflow and outflow, mainly we'll be talking about outflow. This talk is most relevant when we are dealing with patients with one of the high pressure glaucomas like those listed here. But of course, we can still apply some of this knowledge to our normal tension glaucoma patients. Here is a very basic diagram of aqueous flow. I've color-coded the structures according to whether they are part of inflow or outflow. So keep this in mind throughout the talk, and there'll be various versions of this diagram during the talk. So let's start with inflow. Aqueous humor is produced by the non-pigmented epithelial cells of the ciliary body. Every minute, about 1 to 1.5% of the total volume of the aqueous humor is replaced. So that'll be about 2 hours to replace the total aqueous volume. There is a diurnal fluctuation to the secretion of aqueous, with the peak usually in the morning and the trough at night. These values are not exact and vary per study because aqueous inflow cannot be measured directly. We might not be able to measure directly, but it can be estimated using laboratory techniques such as fluorophotometry. This technique estimates inflow by measuring the dilution of fluorescein in the anterior chamber over several hours, because the fluorescein will only become diluted if new aqueous is being introduced into the anterior chamber. Obviously, this technology is not feasible for clinical use. That's really pretty much all I'm going to say about inflow. I'm sure it's quite obvious why we are more interested in aqueous outflow for the purpose of this talk. But if it's not obvious yet, especially for the first years, then I hope it'll become clear as we go along. I believe that if we understand how we obtained our knowledge about the structure and function of the outflow pathways, then we will be better able to appreciate some of the concepts that will follow. So here's a neoprene latex cast made about 70 years ago, showing Schlemm's canal, the collector channels, the deep scleral venous plexus, and the episcleral veins. So take a few seconds to think about the techniques used to make this cast. Of course, aside from injection casting, traditional methods like histology were also used to study the structure of the outflow pathway. Naturally, this could only be done on enucleated globes, and the force needed to inject the latex or silicone tended to create artifacts because of the non-physiologic pressures applied to be able to make the casts. So back then it was all very non-physiologic and always ex vivo. What about measuring the outflow pathway function? One traditional method is tonography, wherein a tonometer probe is placed on the cornea for a few minutes. The IOP slowly decreases, either entirely or partially as a result of the weight or the force placed on the cornea by that probe. The amount of decrease in IOP is then used, together with reference tables, to compute the facility of outflow, and the result is given as microliters per minute per millimeter mercury. I'm sure most of us, myself included, have never seen or used an actual tonography unit. This technique was previously being used in the clinics, but it has fallen out of favor because the results are not very useful for individual patients because of the many confounding factors and disadvantages, though it's still useful for laboratory or research purposes. Fluorophotometry, which I mentioned earlier, for estimating inflow, can also be used for outflow. Again, it's only done in the lab mainly because it takes many hours to do the simple test. Now, there are less destructive methods available to study the aqueous outflow pathways. I said less destructive, but some techniques being used now are still quite invasive. This is an example of aqueous angiography using fluorescein and a Heidelberg spectralis imaging machine on a non-deceased cadaver eye. Note how uneven the flow of fluorescein is as it exits the anterior chamber, with more flow occurring nasally. The injection pressure used for this technique and all of the modern techniques is at physiologic levels, unlike what was used before. So it's now possible to map the outflow pathways much more accurately. Current techniques being used include dyes or tracers. They can provide us with information on both structure and function. Dyes and tracers can be injected into eyes that are undergoing elective surgery or into enucleated globes. So it's still an invasive technique. Imaging, though, can be done non-invasively and can be done both in vivo or ex vivo. So this is the outflow pathway elucidated by research done in the past and that we have learned in the basic course and from our textbooks. There's a lot of exciting research being done on aqueous humor outflow, so our knowledge on this might change or be updated in the next several years. Although we are familiar with this already, there are just a few things I would like to point out about this in the coming slides. So for the first years, by the way, PTM is a posterior trabecular meshwork, and it's made of 3 parts. And then the aqueous flows into Schlemm's canal, then the collector channels, then aqueous veins, then episcleral veins. Here is some of the aqueous outflow structures as imaged by a Heidelberg Anterion, which is the anterior segment imaging machine of the maker of the Spectralis OCT. Take note that the 2 images are not of the same eye. I just want everyone to appreciate the relationships of the structures in grayscale in the image on the left, while using the false color image on the right as a guide. We are all familiar with the anatomy around the angle, but what I want to emphasize here is the relationship of the longitudinal ciliary muscle to the TM via the scleral spur. The reason I'm pointing this out is because its significance tends to be overlooked or not understood. I'll be discussing this more when we discuss treatment. Which anterior chamber angle structure does the aqueous pass through in the conventional outflow pathway? The answer is the posterior trabecular meshwork, or PTM. That's a very common question that the residents are asked, so every first-year resident would know this. But why is the flow only through the PTM and not the ATM also? The reason why there's no filtration across the anterior TM is because there is no Schlemm's canal behind the anterior TM. This white line is the entire TM, both anterior and posterior. See how Schlemm's canal is only present behind the posterior part. I think the reason I'm showing this is that I think it helps our understanding when we know the reason behind the fact instead of just the fact itself. Now that we're on the topic of Schlemm's canal, there are 2 things that I would like to point out. This is an electron microscopy image of an eye that underwent ab interno trabeculectomy using a trabectome. The trabectome instrument strips off and cauterizes the TM and the inner wall of Schlemm's canal. So it leaves behind the outer wall of Schlemm's canal. And what I want to show you here is the collector channel opening seen on the outer wall of Schlemm's canal now that the inner wall has been removed. Here is a representation of Schlemm's canal with the collector channels coming out from the outer wall of the canal. The important thing here is that this space, or Schlemm's canal itself, is not continuous. So actually, this diagram or diagram should actually look more like this. So there are like sort of like septations or divisions within the Schlemm's canal. So it's not one continuous circle. So only these collector channels would serve filtration coming from this part of the trabecular meshwork because it's blocked off by these septations or divisions within the canal. So if we were to implant a bypass device, like an eye stent, to increase the flow, we would only be increasing the flow in this area and not affect the exit of aqueous via the rest of the collector channels because Schlemm's canal is not continuous. This fact is something that we ophthalmologists did not realize until quite recently. So because of the newer methods of studying aqueous humor outflow, we have realized that some assumptions that we previously made about outflow were wrong. And now that we know differently, there are implications to this. For example, having more outflow through the TM in areas near collector channels could explain why healthy older eyes and POAG eyes tend to have uneven pigment deposition on the trabecular meshwork, like what you see here. Several decades of uneven aqueous flow leads to uneven pigment deposition in normal elderly eyes. But in POAG eyes, it takes a much shorter period to produce the same effect. So in a way, we can think of POAG angles as rapidly or prematurely aged angles. I'll be talking more about the effects of aging later. I personally suspect that the more pigmented areas are the areas with greater flow, but it could also be the opposite. That tells us that there's still a lot we need to discover about aqueous humor dynamics. Another thing we can surmise is that having non-uniform flow could partially explain why angle closure patients with equal degrees of closure have different IOP levels. If you have two angle closure patients who both have PAS covering 50% of their angles, those two patients might not have similar IOP levels. Their IOPs could be very different. Those with the lower IOPs probably have the closure of their angles in areas that are less functional. And finally, knowing the segmental nature of the outflow structure, particularly Schlemm's canal, can help us when planning surgical treatment of glaucoma, especially angle procedures. There's also new knowledge from genetic studies. Many POAG-associated genes have been identified that are also involved in endothelial cell morphology. Unlike the trabecular meshwork, which is composed of epithelial cells, Schlemm's canal and the collector channels are lined by endothelial cells that are similar to the cells of lymphatic vessels. Thus, it's very possible that for some POAG patients, dysfunction of the post-trabecular structures are the major contributor to their IOP elevation. A potential clinical implication of this is that it may be possible in the future to predict which patients will not respond well to angle bypass procedures because their outflow pathway dysfunction is much more distal and not at the angle itself. I've mentioned a few times that it's difficult to measure outflow, but there are methods available to us as surgeons to estimate sectoral variations in outflow. Have you ever noticed that when you put the phaco probe into the eye, the episcleral vessels suddenly blanch? See if you can safely observe that the next time you do a phaco or the next time you assist a phaco. This video shows an exaggeration of that effect. So the episcleral vessels are slowly blanching in the superior and nasal sectors. It's exaggerated in this eye because this eye has undergone gonioscopically assisted transluminal trabeculotomy. So there is a lot of flow through those areas. If it was just a plain phaco, the blanching would be a lot more subtle. So in this video, BSS is what's being forced into the episcleral veins. But another method could be to use dye or to just simply lower the IOP, put a gonio lens on the cornea, and see what sectors of the angle have the greatest amount of blood reflux into Schlemm's canal. So those areas with the greatest reflux will be the areas of greatest distal flow. So we can use that knowledge when we are planning, for example, a focal angle bypass procedure like an eye stent. We can target the placement of the stents in the areas with greatest flow. I've been talking about aqueous outflow structure and function, but it has mostly pertained to the conventional outflow pathway. Why is it called the conventional pathway? Because this was believed to be essentially the only outflow pathway until researchers realized that there was another pathway for bulk flow of aqueous. They called the new pathway the unconventional outflow pathway, so they then had to call the original one the conventional pathway. In the decades before 1965, it was theorized that there might be another route of bulk flow of aqueous bulk outflow of aqueous aside from the trabecular pathway. It was finally proven in 1965 in the laboratory. It passes through the interstitium of the ciliary muscle. It cannot be measured directly and can only be estimated or calculated, which is why there is an extremely wide range of outflow results reported. So here's a summary of differences between the two outflow pathways. Take note that these percentages vary widely based on the study and the eye health and the age of the subjects in the study. So you should think of these numbers as really just an estimate. There is another outflow method. Take note it's not called a pathway because the flow is too minimal for it to be considered a pathway. This flow is via diffusion across tissues as opposed to the bulk flow that occurs through the actual pathways. This pseudo facility of outflow partially explains why angle closure patients with completely closed angles do not have IOPs that are through the roof. Although another major reason for that would probably be the strangulating effect of extremely high IOP on the ciliary body's ability to produce aqueous. With aging, there is no net change in the IOP in healthy eyes because aqueous outflow and inflow are proportionately or equally reduced. But the story may be different for eyes with impaired outflow, so we're going to be discussing that some more later. Now that we have had a little refresher on aqueous inflow and outflow, I hope that I was able to emphasize the important facts, but also to show you just how incomplete our knowledge is even up to now and how inadequate our measurement techniques are, especially for clinical use. So let's now move on to discuss the more clinically relevant concept, which is intraocular pressure. Intraocular pressure is produced by a balance between the inflow and the outflow of aqueous. Here's the Goldmann equation that we all learned during the basic course, I hope. It's a simplistic formula for such a complex system, but it still gives us a good rough estimate of the IOP. Dr. Hans Goldmann came up with this equation in the 1950s, so it only accounts for the conventional outflow, conventional outflow pathway. As I mentioned earlier, it was only in 1965 that uveoscleral outflow was proven to exist by Dr. Anders Bill. So uveoscleral outflow should be part of the IOP equation. This is sometimes called the expanded Goldmann equation. But it still does not account for the effect of pseudo-facility of outflow and other complexities of outflow. When inflow is more or less equal to outflow, then the IOP is normal. But whenever there is an imbalance, that can cause elevation in the IOP. Why does an imbalance between inflow and outflow occur? Does it happen because there's excessive inflow? Essentially, elevated IOP is never due to excessive inflow. Theoretically, these entities could exist, but as far as I can tell, they have never been documented. Of course, that lack of documentation could just be because of the difficulty of measuring inflow and the usual multifactorial causes of IOP elevation in people with ciliary body tumors. This is why a discussion of aqueous inflow is not really needed for the purpose of our talk and for the purpose of glaucoma. The cause of elevated IOP is almost always because of a problem with the outflow pathway. But because there are so many structures involved, it can be quite complex and confusing. Determining the site and the mechanism of obstruction is extremely important because the success of our treatment could depend on this. Recognizing if the angle is open or closed is only the first step, because there are different mechanisms or sites involved for each type of glaucoma or outflow pathway obstruction. Let's discuss open angle outflow impairment first. How do we determine the site of obstruction in an open angle glaucoma case? Of course, we should be familiar with the pathophysiology of the different open-angle glaucomas so that we know what signs to look for. Then we need to look more closely at the angle after gonioscopy has already shown us that the angle is open. Gonioscopy is more than just checking if the angle is open or closed. Clues like trabecular meshwork pigmentation or material deposited on the trabecular meshwork surface or blood in Schlemm's canal, these kinds of things can all help us to narrow down the diagnosis, what type of open angle glaucoma it is. We also need to consider the rest of the clinical picture, both the history and the rest of the PE. Knowing the correct diagnosis will lead to correct treatment. For example, the method of treatment of the trabecular obstruction in a POAG case is very different from the management of the pre-trabecular obstruction in a phacolytic glaucoma case. As we learned during the earlier part of this talk, there's a lot of new knowledge and a lot more that still needs to be discovered about the conventional outflow pathway from Schlemm's canal and beyond. It's possible that in the future, we will be able to narrow down which part of the post-trabecular outflow pathway is dysfunctional. Sometimes determining the site or location of obstruction is the challenging part when dealing with an open angle. On the other hand, the difficulty with angle closure is determining the mechanism of obstruction. There are two general mechanisms of angle closure. These are the two general mechanisms. In anterior pulling mechanism, the substance or force that closes the angle is within the angle itself. So here's an illustration of what happens. In posterior pushing mechanism, there is a force posterior to the iris that is pushing the iris anteriorly. Here's what that looks like. How do we determine if the angle closure is due to an anterior pulling or a posterior pushing mechanism? The main indicators are the degree of iris convexity, which would be greater in posterior pushing, and the appearance or what the PAS looks like. They tend to be lower and tent-like in anterior pulling and broader and higher in posterior pushing. But these are not hard and fast descriptors because angle closure cases can have both mechanisms present either simultaneously or consecutively. So as always, the rest of the clinical picture can also provide us some useful information. But wait, there's another level of complexity. There are mechanisms to the mechanism. So I like to think of them as sub-mechanisms. There are different causes of posterior pushing mechanism, and the ideal method for relieving the posterior push varies for each of them. I have an entire talk on the different sub-mechanisms contributing to primary angle closure. I will summarize a 15-minute talk into 3 sentences. 1, there are 3 major sub-mechanisms contributing to varying degrees in so-called primary angle closure. These 3. The iris configuration in different areas and the response of the angle to dynamic and indentation gonioscopy are the main indicators for distinguishing these 3 mechanisms clinically. Treatment options are iridotomy, iridoplasty, lens extraction, or a combination of these, depending on which is the primary sub-mechanism at play. Secondary angle closure due to a posterior pushing mechanism also causes closure through one or more of these sub-mechanisms. For example, a subluxated lens can cause both pupil block and lens block. Of course, whenever there is a secondary cause, then we need to address that cause as much as we are able and not simply use the techniques meant for treating primary angle closure glaucoma. Aside from direct obstruction of the outflow pathway, there's another cause of elevated IOP, which is quite rare. A tight orbit can compress the globe, causing elevation of IOP. However, this almost always occurs in combination with other mechanisms of IOP elevation, like increased episcleral venous pressure. So it's usually difficult to isolate the effect of just the orbital congestion. So this leads us to the next cause of IOP elevation, which is a combination of mechanisms. A good example of IOP elevation due to combined or mixed mechanisms is angle closure that has been successfully treated with iridotomy. These eyes may end up with a mixture of closed and open areas in their angles, but those open areas that were previously closed do not necessarily function normally. So it's like there is also open angle glaucoma in those areas. And then there are those conditions where the mechanism of IOP elevation is different depending on the stage of the disease. Good examples of these are pseudoexfoliation syndrome and neovascular glaucoma. So let's go back to aqueous dynamics for a minute. Here's the original Goldmann equation again. How does impaired outflow, specifically angle closure in this illustration, affect aqueous dynamics and IOP? So don't worry, we don't need to memorize this table, we just need to understand it. If we use the Goldmann equation to compute the IOP in a normal eye, an eye with a half closed angle, and an eye with the 3/4 of its angle its angle closed, these are the values that we get. The main thing I want to illustrate with this table is the wide diurnal fluctuation that a small amount of inflow variation can produce when the outflow is impaired. See how different the IOP is when inflow is 1.5 microliters per minute versus when it's 3 microliters per minute in a normal eye. Then see how different it is, how much bigger the difference is in diseased eyes. So 21.5 versus 34, or 34 versus 59. I included the 4.5 microliters per minute inflow because this has been reported, but I really just included it to illustrate the differences more. So although I used closed angles in this example, it also applies to open angle glaucoma. But the problem with open angle glaucoma is that we have a less clear idea of just how severe the outflow impairment is because we can't actually see just how much of the angle is not functioning. Unlike with closed angles, we can actually count how many clock hours or degrees are closed. Remember what I said earlier about aqueous dynamics in aging? While the decrease in aqueous secretion usually balances out the decrease in trabecular function, this may not be the case in impaired angles. In an aging eye with impaired outflow, the decrease in function of the remaining open areas may produce an out of proportion decrease in outflow function. So despite the decrease in aqueous secretion, the IOP might still actually go up. So we need to consider this when our glaucoma patients are getting older. Having a greater understanding of the many complexities of the causes of IOP elevation can help us make better decisions regarding treatment. There are many options available to us that work in different ways. There's different types of treatment and there's different tissue targets. Tissues that can be targeted with laser are the ciliary muscle for micropulse diode laser. Take note, micropulse diode is different from diode cyclophotocoagulation. Another tissue target is the iris in iridotomy and iridoplasty, and the trabecular meshwork in trabeculoplasty, whether the trabeculoplasty is selective or argon laser trabeculoplasty. Glaucoma medications, on the other hand, they act by either decreasing outflow or by increasing outflow through one of the outflow pathways. These are the classes of medications color-coded according to their main mechanism of action. So the color coding depends, it matches where they act. Some of these drugs may have a minor secondary mechanism that may either be actually measured or it may just be theoretical. But I've put them into the category according to their main mechanism of action. I didn't include osmotics because they are only used as rescue medication. So it's important for us to know what tissue or pathway is affected by each of the medications we use so that we can make better treatment decisions. So take note, I'm using the newer, more encompassing term, prostaglandin agonist, which refers to prostaglandin analogs, prostamides, and prostanoid receptor agonists. Here is the anatomy I wanted you to take note of earlier. This is a good example of how knowing the anatomy of the outflow structures helps us to better understand treatment. Many ophthalmologists now use pilocarpine only for pre-laser preparation, especially prior to iridotomy of angle closure eyes. They have forgotten that pilocarpine's primary use in glaucoma is actually to increase trabecular outflow in open angle glaucoma by opening the TM spaces via contraction of the ciliary muscle. So pilocarpine acts on the ciliary muscle, but the end result is improved trabecular outflow. These are the general principles to guide our treatment decision-making process. Whenever possible, we should directly address the mechanism and the tissue involved. An example of directly targeting the diseased tissue for treatment would be doing a laser trabeculoplasty for an eye with POAG. We should also leverage areas with existing outflow by enhancing their outflow. An example of this is treating POAG, which is a trabecular disease, by increasing uveoscleral outflow with a PGA. If combination treatment is needed, choose treatments that have different modes of action. I'm not just referring to combinations of medication. This principle can also be applied when combining medication and laser, for example, or even laser and surgery. For example, a good combination for a POAGI is SLT for the conventional outflow pathway, plus a medication that either targets inflow or the uveoscleral outflow pathway. Another example of a good combination would be in an eye with PACG that needs lens extraction to relieve the pupil and lens block, but might still need iridoplasty afterwards if there is a large plateau iris component that's contributing to angle block. Surgical techniques for lowering IOP are all bypass methods of varying degrees, whether it's just one tissue being bypassed like the eye stent or a complete bypass like a trabeculectomy. For this, we should consider not only the type of outflow impairment, but also how to take advantage of the existing or remaining outflow. And then as a last resort, we can also turn off the tap. The key points of this talk are that IOP elevation is almost always due to a problem with the outflow. Outflow impairment is not as simple as it might seem, and we need to try to identify as much as possible where and how the outflow is obstructed so that we can make better treatment decisions and we can tailor our treatment to provide better outcomes for our glaucoma patients. So these, aside from the references directly stated in the slides, these are my other references. So thank you for listening.